Hello everybody. Welcome to no1doctor channel. Today video is about initial survey, the ABC, in trauma patient, which is part of our playlist called Short Medical Notes, in which we will have short videos about important topic in medicine. Please do not forget to like, share our videos, subscribe to our YouTube channel no1doctor, and join our social media accounts in the links below each video. Our aim is to share the correct medical knowledge for all for free. Please share and be shared. 1. Airway. An airway is present if the patient is conscious and speaking in a normal tone of voice. The airway will soon be lost if there is an expanding hematoma or emphysema in the neck. An airway should be secured before the situation becomes critical. An airway is also needed if the patient is unconscious, with a Glasgow coma scale of 8 or under, or his breathing is noisy or gurgly, if severe inhalation injury, breathing smoke, has occurred, or if it is necessary to connect the patient to a respirator. If an indication for securing an airway exists in a patient with potential cervical spine injury, the airway has to be secured before dealing with the cervical spine injury. An airway is most commonly inserted by orotracheal intubation, under direct vision with the use of a laryngoscope, assisted in the awake patient by rapid induction with monitoring of pulse oximetry, or less commonly with the help of topical anesthesia. In the presence of a cervical spine injury, orotracheal intubation can still be done if the head is secured and not moved. Another option in that setting is nasotracheal intubation over a fiber optic bronchoscope. The use of a fiber optic bronchoscope is mandatory when securing an airway if there is subcutaneous emphysema in the neck, which is a sign of major traumatic disruption of the tracheobronchial tree. If for any reason, laryngospasm, severe maxillofacial injuries, an impacted pharyngeal body that cannot be dislodged, etc., intubation cannot be done in the usual manner and we are running out of time, a cricothyroidotomy may become necessary. It is the quickest and safest way to temporarily gain access before the patient sustains a noxious injury. Because of the potential need for future laryngeal reconstruction, however, we are reluctant to do it before the age of 12. 2. Breathing. Hearing breath sounds on both sides of the chest and having satisfactory pulse oximetry establishes that breathing is okay. 3. Shock. Clinical signs of shock include low blood pressure, BP, under 90 mm Hg systolic, fast feeble pulse, and low urinary output, under 0.5 ml/kg/H, in a patient who is pale, cold, shivering, sweating, thirsty, and apprehensive. In the trauma setting, shock is caused by either bleeding, hypovolemic hemorrhagic, by far the most common cause, pericardial tamponade, or tension pneumothorax. For either of the last two to occur, there must be trauma to the chest, blood or penetrating. In shock caused by bleeding, the central venous pressure, CVP, is low, empty veins clinically. In both pericardial tamponade and tension pneumothorax, CVP is high, big distended head and neck veins clinically. In pericardial tamponade, there is no respiratory distress. In tension pneumothorax, there is severe respiratory distress. One side of the chest has no breath sounds and is hyperresonant to percussion, and the mediastinum is displaced to the opposite side, tracheal deviation. Management of pericardial tamponade is based on clinical diagnosis. Do not order X-rays. If diagnosis is unclear, choose a sonogram, and centered on prompt evacuation of the pericardial sac by pericardiocentesis, tube, pericardial window, or open thoracotomy. Fluid and blood administration, HLE evacuation is being set up is helpful. Management of tension pneumothorax is also based on clinical diagnosis. Do not order X-rays or wait for blood gases. Start with big needle or big IV catheter into the affected pleural space. Follow with chest tube connected to underwater seal, both inserted high in the interior chest wall. Management of hemorrhagic shock includes two components: stopping the bleeding and replacing the lost blood. Bleeding from the extremities is controlled by direct pressure in the single civilian patient who shows up in a fully staffed emergency room. When there are multiple injured people in either the military or civilian setting, we resort to tourniquets. Internal bleeding in someone who happens to be near a trauma center is best dealt with by surgery followed by the replacement of the lost blood. But if the patients are far away from hospital facilities, by necessity we have to start replacing the blood volume as we transport them, as quickly as possible, to where the life-saving operation can be done. We know that the best replacement for lost blood is whole blood. The military has extensive experience with that notion. Soldiers are excellent blood donors who willingly come to the help of their injured comrades. In the civilian setting, we have not been so fortunate. Blood is a scarce resource, and thus blood banks break it into its various components to make better use of it. Historically, if we wanted to give whole blood, we had to reconstitute it by mixing packed red cells, fresh frozen plasma, and platelet packs in a 1:1:1 ratio. Think about that for a moment. What comes out of a blood donor is whole blood. We go through effort and expense to break it down, and then take more steps to put it together again for a seriously injured patient. Weird. The management of trauma is becoming a highly organized effort, with areas of the country allotted to level 1 centers and appropriate transportation provided. Many of those ambulances and helicopters now carry whole blood from universal donors to be given as the resuscitation fluid en route. The survival improvements have been so dramatic that we may soon have no further use for ringer lactates or blood components in the severely injured. Preferred route of fluid resuscitation in the trauma setting is 2 peripheral IV lines, 16 gauge. If they cannot be inserted, percutaneous femoral vein catheter or saphenous vein cut-downs are alternatives. In children under 6 years of age, intraosseous cannulation of the proximal tibia is the alternate route. Thanks for watching our video and hope to see you again in next videos. Do not forget to see other videos in our channel. With my best wishes. Dr. 8 Famid.